I'm going to start with a question by Kate, and you address this a little bit, Dr. Raje. Can you stop denosumab or Xgeva abruptly? And do you want to both explain why that happened, why you need to do that? Because we had a very nice session with Matthew Drake from the Mayo Clinic at one of our roundtables, and he went through a lot of the detail, but I think the two of you could give the why behind that.
Sure, I'm happy to start. So, denosumab is a monoclonal antibody. It's a ranked ligand antibody, and it's reversible. So, if you suddenly stop denosumab, what will end up happening is activation of those so-called osteoclasts, which are the bone-destroying cells. And that's something we've seen in the osteoporosis literature, that suddenly stopping it actually makes those osteoclasts work even harder and put you at a risk for a fracture. So typically, if there is a reason for you to stop the denosumab, my recommendation would be take zoledronic acid or Zometa at the back end of that, because drugs like zoledronic acid stay in your system forever, and they will actually prevent that osteoclastic overactivation and the risk of fractures from suddenly stopping denosumab.
Mm-hmm. Dr. Gertz, do you have any comments about that subject?
I think that summarizes it quite well. You rebound if you stop it. And the reports actually were in patients who were receiving the drug for solid cancers, not so much myeloma, but the assumption is that if that's what occurs in solid cancers, it's likely it will occur in all patients in which it's administered.
Okay. This question, Dr. Gertz, maybe you want to start with this question from Mark, and I want to ask it in a broader way. He's asking, is there a relationship between trisomy 21 and bone disease? But I do notice that in myeloma patients, some patients have highly aggressive myeloma but very little bone disease, and some patients have slower growing myeloma but a lot of bone disease. Do you want to address the genetics of myeloma and bone disease?
Well, I'll say that 20% of patients with myeloma never in their entire course ever develop bone disease. And the drivers of their clinical course are the protein damaging the kidney or replacement of the bone marrow causing blood transfusion dependent anemia without any bony destruction. And there's a very, very poor correlation between the percentage of plasma cells in the bone marrow and indirectly the amount of abnormal protein or abnormal light chain or free light chain in the blood and whether bone disease will or won't be present. You can't look at the international stage. You can't look at the bone marrow plasma cells or the proteins and predict which patients will have bone disease and which ones won't, other than 70% do. But there are patients who have 70, 80% plasma cells in the bone marrow and normal bones. And more importantly, there are plenty of patients who have 5% plasma cells in the bone marrow, widespread destructive lesions. And in fact, these patients are understudied because in most trials, by mutual agreement, you're not eligible unless you have 10% plasma cells in the bone marrow. But that doesn't mean that if you have less than 10% plasma cells in the bone marrow, 5 or 8, that you can't get a fractured arm, fractured spine. And so frankly, we have a lot of biologic predictors of outcome, response duration, predictors of what's the best maintenance therapy, but I don't think there's very good measures that allow us to blindly determine which patients will and won't develop in the clinic bone disease.
And Dr. Raje, do you have any comments about that?
Yeah, no, I, totally agree with Maury. I will just add, the question about the genetics piece here, Jenny. The one thing we've not been good about is correlating the genetics of myeloma and the risk of developing bone disease. So the question of whether 1q amplification will be more likely to get bone disease, I don't think we have data to support that. Whether 11-14 translocated patients have more bone disease, again, unclear. And I think the biggest problem with myeloma bone disease in my mind is despite the fact that the majority of patients have bone disease in myeloma, it doesn't play into the staging system or the risk stratification for myeloma. And that to date is a problem.
Mm-hmm. Okay, another question that's kind of common, and Melissa was asking this question, and I saw that Avery asked it also. So for people who are diagnosed with MGUS or smoldering myeloma, like Melissa was diagnosed with MGUS IgG lambda, no lesions, but bone pain throughout her legs and hands, and Avery said the same thing. Why do these early precursor condition patients, why are they experiencing bone pain without having active myeloma? I'll let you both.
These patients need further investigation. Their patients with monoclonal gammopathy of undetermined significance unequivocally have a higher rate of osteopenia and osteoporosis. But osteopenia and osteoporosis are not painful conditions. And so these individuals need investigations, peripheral neuropathy, musculoskeletal conditions, connective tissue disorders, fibromyalgia, I don't know, but it would be incorrect to assume that their pain is related to the monoclonal gammopathy. Some of these patients turn out to have POEM syndrome that we see, occasional patients with G lambda and foot pain or leg pain, they actually have amyloidosis. And so by definition, MGUS has no symptoms associated with it. And if there's symptoms associated, you need to look a lot harder to define it. It'd be, I think, a diagnostic error to assume this is related to the monoclonal protein.
Mm-hmm. Dr. Raje, do you agree?
Yeah, I totally agree. And I think Maury made a very important point. You have to, in this situation, rule out neuropathy. So MGUS with neuropathy is seen, and it's really important for the caregiver to make sure that that's ruled out completely.
Mm-hmm. Okay, good. So Mariana has a great question. So if you never had bone damage at diagnosis, you've had control of your myeloma for 5 years and then you relapse, there's always an opportunity to have bone damage, right? So in myeloma, whether you had it at diagnosis or not, do you want to address what you should be looking at in terms of a complete relapse diagnosis?
Sure. So even if you didn't have it at the outset, you are at a risk for bony-related problems throughout the course of your myeloma. As Dr. Gertz has pointed out earlier, because we're able to control the myeloma clone so well now, we're seeing less and less of that happen. But I look at it in a slightly different way. We have patients who are living a lot longer with myeloma, who remain on treatment a lot longer, so their risk of developing bone-related problems over time increases. So even at the time of relapse, whether you had bone disease at the outset or not, you should do a full workup, which should include blood testing, urine testing, a bone marrow test. And for bone disease, we've replaced, as I've mentioned, skeletal surveys. We don't do anymore because of lack of sensitivity, but at least a myeloma CT survey should be done in that patient. And in some situations, we would do things like a PET scan or an MRI, and that's patient dependent, but absolute complete workup needs to be done. The other thing I will also say is, even if you didn't have bone disease and you have active disease now, as long as you're getting treatment for your active myeloma, you should be receiving a bone targeted agent as well.
Okay, good point. So Lisa has an interesting question that I've never heard before. Do any of the newer osteoporosis drugs interfere with the immune system? Like Prolia, for example, is a monoclonal antibody. While it may help grow bone, could they also help myeloma progress, or is it going to get in the way of any myeloma therapy?
So the studies that have looked at this, the ones with the bisphosphonates, the zoledronic acid, trade name Zometa, and the pamidronate, trade name is Iridia, compared to placebo, did not show higher infection rates. So I can't talk about the specifics of the immune system, but the infection rates, pneumonias, blood infections were not higher. And in Dr. Raje's study, looking at denosumab, which is Prolia or Xgeva, those are the trade names, compared with zoledronic acid, also the infection rates were not appreciably higher. So I'd have to say that at least from the clinical endpoint of an impaired immune system leading to an increased risk of infections, it's a no.
So I'm just going to add one thing to that, Jenny. The bisphosphonates for a long time have been shown that they activate certain gamma delta T cells, and those are good for your immune system. And at least our lab data where we've studied denosumab in the context of the immune system, we think it actually promotes it. And that may be part of the reason why when denosumab was compared to zoledronic acid, you saw better control of the myeloma. So certainly doesn't have a negative effect, but it may in fact have a more positive effect on the immune system.
Okay, great. That's great to know. Okay, so you both addressed a little bit osteonecrosis of the jaw, and here's some specific questions, one by email and others by the chat. So Susan was put on Xgeva, had a small erosion of gum causing jawbone protrusion. Her last dose of Xgeva was in January or 2020. They don't want to really do the graft. So what does somebody like that do? And then Patrick also asked, you talked about stopping it, trying to avoid dental work, essentially, or major kind of dental work if you're on a bone strengthener. But can you stop for a few months, get the dental work done, and then restart? And if so, what's that time span look like? Dr. Raje, do you want to start?
Typically, we ask, sometimes you cannot predict when that dental work has to be done, but typically we like to give a 3-month window. And this is just based on what happens with these bone resorption markers. And again, once that ONJ is healed, the discussion we have with the patient is the risk of bony related complications versus how bad the ONJ is. There's a lot of patients where once you get healing of ONJ, we've gone back onto the bisphosphonate because the risk of the bone disease is quite significant. Again, if somebody's received just denosumab, at least giving 1 dose of zoledronic acid at the back end would be a good idea. Certainly less frequent dosing would be what would be recommended.
In answer to the specific question, it really depends on whether there's pain. So just having loss of the overlying gum tissue with exposed bone is not mandatory to have surgery. The real issue is whether there's pain or no pain. If there's no pain, there's no rush to do anything. You sit tight. It's very difficult for gum tissue to grow over devitalized bone in the jaw. It's not getting blood supply, and so it can't sustain bone overgrowth. However, if at 11 months there's intense pain due to the exposed jaw, then I think an oral maxillofacial surgeon will consider grafting it. But the question isn't, is there exposed bone? The question is there pain?
That's a great point. Okay, good delineation. So Janine is asking, you talked about, Dr. Gertz, you talked about kyphoplasty a lot and things you can do for the spine. If you have bone damage in your sternum, is there anything that you can do?
Regrettably, it's pretty minimal. For those who aren't familiar, one of the areas, fortunately uncommon, where these destructive lesions can occur are in the sternum. And if they're severe enough, you can present with a sternal fracture. And sternal fracture, quite frankly, and unfortunately, redefines what pain really can be. Because I talked about how you can control your pain by lying perfectly still. Well, your sternum can't lie perfectly still. No matter what you do, you're turning, you're sitting up, you're breathing, and sternal pain is really horrible. And my heart goes out to those individuals that have sternal fractures. I will tell you that it's been my pretty uniform experience that although the pain can just be horrid for 60 to 90 days, realistically, with good current therapy, healing is pretty prompt. If it didn't cause prompt response, I think it would be an area where localized radiotherapy would be justified, because the pain really can be quite extreme, unfortunately.
Mm-hmm. Okay. We also have questions about fitness or exercise that you can do with or without bone destruction. I can't find the question, but I know there was a question about skiing. And Deborah's asking, do weight-bearing exercises help? So I know this is a conversation that everyone should have with their doctor individually, but can you go over just what's helpful, what's not helpful, what should you stay away from, what should you consider doing?
I think staying active is really important. The more active you are and the more mobile you are, the better your outcome is going to be in general. Now, if you have a huge lytic lesion in a weight-bearing bone, for example, the humerus or the femur, that needs to be paid attention to, and that's the part which you would surgically intervene on and fix, because that would be at a risk for fracture. So if you have something like that, until that area has been taken care of surgically, I would avoid weight bearing. But outside of that, I think exercise is absolutely a good thing. The one thing I will say is, when you have a lot of spine related lesions, can be difficult to exercise, but things like water aerobics and swimming is actually extremely helpful, because it allows building paraspinal muscles, and that helps support the spine a whole lot better. So the more physically active you are, the better. In terms of weight bearing and in terms of weights, etc., up to 20 pounds is generally, in most cases, quite safe to do. But if there's a specific lesion, have a conversation with your treating doctor and then decide what's safe for you. Skiing should be okay. No reason why people can't ski.
So a couple comments. It's a really important question. Mark Kelly, an astronaut who spent 12 months in the International Space Station without gravity, came down and lost 10% of his bone mineral mass. One of the great concerns about sending a manned mission to Mars, which would be 2 years in space, is the concern that there's going to be so much bone mineral mass, they're going to get fractures when they land. So there's no question that weight resistance activities helps maintain your overall bone mineral mass. And so I strongly advise people. So for example, I don't like them doing exercises that stress their spine. I worry about the spine a lot. But in terms of using a dumbbell, 1 pound weights or 2 pound weights, sitting in a card chair or walking are absolutely fine. And aerobic activities like skiing, people who are aerobic, normal, not myeloma, have higher mineral mass than people who don't. But again, it's not the skiing, it's the falling. This doesn't mean we're saying good to go back on the double black diamonds when you have known extensive myeloma bone disease, because there are risks. And people ask about cycling. Cycling's good, falling's not good. So you just need to have the awareness of what would be your trauma risk if you engage in these activities. But by and large, the activities are strongly recommended.
Mm-hmm. Yeah, I agree. Thank you. I'm glad that's the word from the experts too, because it's helping with everything, especially right now. It's helping you just get outside, and it's helping mental health and physical health, and helps you qualify for other myeloma therapies in addition to that. So Tom has a question, an interesting question, that there was some thought that Zometa might have antimyeloma properties. Is he correct in understanding that that's unfounded, or is there truth to that? And then when you talk about duration, how long should patients, my doctor I know talked to me and said, some of these bone strengtheners will stay in your system for a very long time, up to a decade. So how long should patients be on these?
So I think everybody is different with that. I'll answer the first question first, the Zometa and the anti-myeloma activity of Zometa. So that was the UK trial that I showed you. And that trial, for the first time, we uniformly treated patients for their bone disease. And it did show that myeloma is controlled better if you're on Zometa. And this was independent of what anti-myeloma therapy is. So that was the first suggestion, that there may be in some anti-myeloma activity. And we found the same thing when we compared zoledronic acid with denosumab able to control the myeloma a little bit better, again suggesting that there may be some anti-myeloma activity. So treating the soil, so to speak, might certainly have an impact on the disease itself for sure. As far as how long to treat, that's a really important question. And if you look at the data, we don't have a lot of good clinical trials, but I think it's safe to say that when you are actively being treated for your myeloma, you should certainly be on the bone targeted agent. Over time, we certainly decrease the frequency, and I've shown you some data with that, every 3 months, even go to every 6 months, sometimes use osteoporotic doses once a year. I typically don't stop a bone targeted agent unless a patient has trouble with it, but doing once a year, once 6 months really reduces the risk of long-term complications. You're almost treating osteoporosis when they are in remission. The other thing I'm just going to again underscore is throughout the course of your lifetime, as your myeloma comes back, you are still at a risk for bone-related problems, and therefore you should be treated with it. Certainly the frequency and the intensity of the bone-targeted agent can be modified over time.
Mm-hmm.
I guess the only addition I'd have with regard to the anti-myeloma properties of bone agents is that the Eastern Cooperative Oncology Group did a small pilot study looking at smoldering myeloma and monoclonal gammopathy and placed these patients only on bisphosphonates and could not demonstrate that it prevented the development of multiple myeloma. And so at the very least for MGUS and smoldering myeloma patients, at least at Mayo, and there may be variability globally, we don't use bisphosphonate therapies in patients that don't have proven bone mineral loss.
Okay, really good point. That's important for these precursor condition patients to know. So I have a sophisticated question by a hematologist who has myeloma, Stephen. Why are not all patients with myeloma and or those on steroids routinely evaluated with bone resorption markers? Urine DPD is very sensitive and a helpful way to monitor excessive osteoclastic activity. Do you agree? Dr. Gertz, do you want to start?
Well, sure. I mean, I'm at Mayo, so I basically in these situations work for Matthew Drake. And so he routinely follows, NTX and always is careful with vitamin D levels to be sure there isn't antecedent vitamin D deficiency, which is 50% at least in Minnesota. And so they're followed. But if you look at the recommendations from the myeloma working group about the widespread use of agents to prevent bone resorption, those decisions are not made on the bone turnover markers, that no one's using low bone turnover markers as an indication. Say, okay, you can stop your bisphosphonate, bone turnover is low, or bone turnover is high, so you need intensification of your therapy. I don't think that those markers of turnover have translated into management strategies for our patient population.
Mm-hmm.
Yeah, no, I would agree completely. We did try and do studies with this where we used antilopeptide to try and tailor therapy. The problem with antilopeptide measuring is once you get on a bone targeted agent, they all tend to be suppressed. And unless you have a rip-roaring skeletal related event, it's not going to go above the threshold for you to change treatment. And that's part of the reason why we've not included this in our recommendations. We do it in occasional cases, but it's not a recommendation.
Mm-hmm. And we had a question about more specifics to Dr. Raje, that you suggested calcium and vitamin D supplements. Do you have any thoughts, both of you, on quantities?
Sure. So, at the time of diagnosis of myeloma, everybody should be getting a vitamin D level assessed. And the WHO recommendation for vitamin D supplementation is 2,000 international units. If your vitamin D deficient, that means a level of less than 30, sometimes your treating doctor is going to put you on higher doses of vitamin D until you get to that level. Before you start a bone targeted agent, we typically will not recommend calcium supplementation, only because of what Dr. Gertz told all of us is leaching of calcium from your bones causing hypercalcemia, which can affect the kidneys. But once you've started a bone targeted agent, one of the side effects of a bone targeted agent is hypocalcemia, and therefore most patients should be on 500 milligrams of elemental calcium. Occasionally, if you're on a drug like denosumab, you may be more hypocalcemic and you might require a higher dose of calcium. But that calcium and vitamin D needs to be monitored, and these are sort of the recommendations for supplementation.
Mm-hmm.
One caution. So the National Osteoporosis Foundation recommends 1,200 milligrams of calcium a day, which is usually 2 tablets of most calcium supplements. And the recommendation is 800 to 1,000 international units of vitamin D daily. One thing I've seen in my practice I see patients showing up and they're taking 50,000 units of vitamin D a week. That's nuts. Vitamin D is a fat-soluble vitamin. It stores. You don't get rid of it. It sits in your liver, and you can get dangerous complication from hypervitaminosis D. So you can definitely not take enough, but you can definitely take too much. And so you want to be kind of rational about this. And there are well-established guidelines all over the place about what are rational amounts of calcium and D, which are required for all patients indefinitely.
And you can go ask for that. I've never had this value run on my labs before, but you can't ask your doctor to run that value, right? So you can kind of see where you're at.
Yeah, you have to have a Medicare qualified indication, of which myeloma isn't one of them, but you can usually find one.
Okay. Also, we've had a lot of questions about nutrition. So we talked about vitamins anyway. Do you want to address anything in the supplements or nutrition that patients always want to know? What can I do to improve my bone health? In general, is there anything that they can do?
Eat healthy and exercise. And the calcium vitamin D supplementation is important, but outside of that, there's nothing different that one would expect to do.
Yeah, it's an uphill battle because there's a multi-billion-dollar nutritional supplement industry we're up against. And 50% of my patients are taking nutraceuticals, biotin, they're taking zinc. Nobody knows why they're taking any of these things. I certainly don't know. I think the issue with myeloma is you're looking for a normal body mass index and you're looking for aerobic activity for a strong heart, and spending hundreds of dollars a month on supplements, which have certainly no anti-cancer properties. And I think it's pretty iffy whether they have any benefits at all. I'm waiting for the published survey of how many physicians in practice are taking supplements.
Yeah. Dr. Raje, yeah, you both already covered this. Okay.
Well, Jenny, while we're on it, there's one thing I just should mention. Fortunately, it's only 1% of patients, but it's a different type of skeletal event. And that is everyone's favorite drug, as you all know, is dexamethasone. And continuous exposure to dexamethasone weekly over many years in 1% of patients can cause a devastating problem referred to as aseptic necrosis of the hip. And it's a circumstance, again, it's 1 in 100, but you've got 600 people online, so you may have 5 people where after years of exposure to dexamethasone, patients develop persistent hip pain and they can't weight bear, and it's not related to the myeloma and radiation's not fixing it. And I think it's difficult to diagnose without MRI imaging of the hip. And truthfully, the only treatment for it is aseptic necrosis. So it's not a skeletal event related to myeloma, but a skeletal event as a long-term consequence of dexamethasone or prednisone.
So Jenny, I'm just looking at the chat also, and there's some interesting questions. One is about what are your thoughts on denosumab, which is
Can you explain
an
what that is?
Yeah, it's the antibody against sclerostin. That was the protein that I showed you. So again, the osteoporosis data looks good, and these are the bone anabolics that we talked about earlier. And we will be studying this in the context of myeloma. So stay tuned. We'd be very interested in doing this. There's one question, Maury, which I'm just going to ask you that they've come up with. How do you differentiate whether bone osteopenia in a smoldering myeloma patient is just osteoporosis and age-related or related to the myeloma clone? Do we have
there's a
Thank you for asking me that, because I have no idea. I don't think it's very easy to distinguish what is a simple age-related phenomenon for which a bisphosphonate once a year or an oral bisphosphonate weekly or monthly is appropriate, and what is an early start of myeloma bone disease. I don't think it's easy to distinguish. In some of these patients, I'll do an MRI because I'll be looking for bone marrow signal to be sure I'm not seeing small little defects in medullary bone, in the bone marrow, that would suggest there are small myelomatous areas. It's not I don't routinely do imaging in MUGUS patients or low-risk smoldering myeloma patients, but if a patient is known to have a significant loss of bone mineral mass, then you want to look just to be sure that you don't have something that it's important to understand that osteoporosis is not a myeloma defining event and is not an indication to initiate therapy, but it's going to affect how you monitor patients if you see it. But on its face, bone mineral loss associated with MUGUS or first phase of myeloma, I don't think that there's a one-size-fits-all correct answer. It's a tough one.
Yeah, there was another question about osteoporosis related to smoldering myeloma. You kind of answered that question. We might not know, if it's just osteoporosis age-related or smoldering myeloma. Important. Okay, well, there's a question that we received also about extramedullary myeloma and plasmacytomas out of the bone marrow that we received by email. What types of do you use bone strengtheners in those situations, or what are the most effective myeloma therapies that are out there today? It's not totally bone related question, but an important one.
Yeah, no, I think we're seeing more and more of this as patients are living longer. So it's, we are seeing myeloma become independent of the marrow and go to these different areas. This is the one place that I did mention we do use things like PET imaging to better evaluate patients. And certainly, if it's all soft tissue, it doesn't provide the rationale for bone targeted, but a lot of these are coming from medullary bone, also the plasmacytomas, and in that situation you will use a bone targeted agent. As far as treatment for these conditions, this is a tough group of patients to treat, but most recently now with all of the BCMA sort of targeted agents and approaches that we have, like belamaf, like CAR T cells, like BiTEs, they're quite effective with patients with extramedullary disease as well. And we've used good old chemotherapy in these patients as well. Alkylating agents tend to have a nice response in these folks.
There's also a question from Howard And you talked about this a little bit earlier, Dr. Raje, but like at what point do you radiate? When do you radiate? When do you not radiate? And what do you suggest there?
So Dr. Gertz brought this up actually, avoid radiation
Yeah.
is something we should try and do. And that's largely because of how effective our treatments are. In the old days when we didn't have a lot of effective treatments, yes, sure, we irradiated. The problem with radiation is you're going to impact your blood cell counts, and you don't want to do that. Having said that, there are certain situations, and we talked about one of them, which Dr. Gertz brought up, the sternal pain. What we do if you're using radiation for pain control, where sometimes you absolutely need to use it, we typically will use 1 or 2 fractions so that we do not compromise the bone marrow reserve in these patients. And the other places where I think radiation is actually useful is if you've surgically pinned a long bone, for example, or there's evidence of cord compression from a vertebral compression fracture or a plasmacytoma affecting the spine, which is compressing on the nerve roots. That's when we have ended up using radiation if we don't have effective treatment at that time.
Mm-hmm. And Dr. Gertz, do you want to address rib pain? I know Teresa had a question. How do you handle rib pain?
Yeah, rib pain's a little tricky. I've seen many patients over the years who have persistent rib pain despite very effective chemotherapy. And I don't know if that's because the continuous motion of the thoracic cage prevents the rib from healing. Rib pain typically is not severe and intense, and the majority of them respond quite nicely to systemic chemotherapy. But I've been faced with situations where very reliable patients have persistent pain, even though it's clear the myeloma is under very, very good control and it's bothersome enough. And we've actually had the radiation oncologists give postage stamp size radiation fields over the fracture site. The majority of patients actually, though, usually present with it, and they're 60 days into it, and really the overwhelming majority, complete resolution of the rib pain. It responds quite nicely to systemic therapy.
Mm-hmm. Okay, thanks for addressing that, because I know a lot of patients have that as an issue. Todd's asking, is there a role for DEXA scans? So can you both explain what a DEXA scan is and why you would or wouldn't use one?
So I can get started. So DEXA scan is something we use to look at bone density in patients. It is the diagnostic tool for osteoporosis or osteopenia. In myeloma, if you have advanced bone disease in the way of lytic lesions, you are going to get treated, you are going to receive bone targeted agents, and I will typically not necessarily do a DEXA scan in those patients, but I follow patients with whole body low dose CAT scans, and we are keeping them on bone targeted agents. I think the situation of a DEXA scan is mostly in the patient which Dr. Gertz described, the smoldering myeloma patient, where you have osteopenia or osteoporosis. You're not completely able to distinguish the two after you've done your initial whole body PET or MRI with a bone density scan. When there's no change and you're treating osteoporosis, those are the patients I would follow with bone density DEXA scan. Typically, we don't use DEXA scans otherwise in our patients.
I agree. I don't either. I think there's a big distinction between bone demineralization and bone destruction. And you can have patients with widespread myeloma bone disease and a normal DEXA scan. So what? Those patients need supportive therapy for the reduction of skeletal events. And so since virtually all myeloma patients are receiving bone targeted therapy, I find the DEXA scan kind of superfluous because I'm already committed to ensuring that I do everything I can to prevent skeletal events. And I don't find that it adds very much, with the exception of the MGUS smoldering patient, where there you would normally not treat, but in the presence of bone mineral loss, it would actually make a difference in how you manage.
Yeah, it might be a good indicator. So, okay. Well, that's great to know. I've worked with several myeloma specialists for my own care. Most have never run it. And then I had one that always ran it. So I didn't understand that either. Okay, William's asking a good question. Benign exgiva, 15 months out from stem cell transplant, developed osteonecrosis of the jaw. If you develop that, I know the presence of exgiva versus zometa, it's kind of about the same, right? The levels of potential ONJ, but can you move to anything else if you develop that? Is there anything that you should switch to if that happens?
So as of right now, I don't think we have an alternative. What, with ONJ, and Dr. Gertz pointed out really quite nicely, just the exposed bone typically should not cause problems. When you have the pain, it's usually a secondary infection of that exposed mucosal surface. And that's why being on antibiotics, once that has been well controlled, going back on a bone-targeted agent is actually important. Whether you use denosumab or zoledronic acid, it doesn't matter because both put you at a risk for bone-related problems. This is where I do think, again, bone anabolics are going to come a long way. We have used sotatercept, the data which I showed you, and hopefully we will use ramucirumab, which is the anti-sclerostin antibody, in the near future. And that will, I think, in my mind, decrease the incidence of some of these long-term complications.
So these are important teaching principles now. So when the first trial of pamidronate was performed, Iridia, the myeloma treatment in over half of the patients was melphalan and prednisone. And skeletal events were seen during the trial in 60% of patients. Nobody sees that anymore because of a more effective therapy. So here, the question that comes up is, after stem cell transplant, has the patient achieved a very good partial response or complete response, where therapy might have been changed to quarterly instead of monthly, asking the question, frankly, could this episode of osteonecrosis been prevented by less intense therapy? In the original studies, at 36 months, 7% of patients developed osteonecrosis of the jaw because everybody got it monthly indefinitely. Nobody sees 7% now. It's 2%, 1%. And so you start asking yourself, at what point is the risk of developing this jawbone complication higher than the benefit you're getting? And so this is a case example for other people on the line saying, is my myeloma such that I need to continue it monthly? If I'm getting it quarterly, do I need to continue it quarterly? Stringent CR, maybe MRD negative. So those are important things for discussions with the provider.
Yeah, good questions. And thank you for your amazing answers. This is why we need experts. This is why we go to myeloma experts. And I always say that in every program that we have. But truly, if you are not being seen by a myeloma expert, you should at least get a consult. And I think with the telehealth situation the way it is, I think it's a perfect time to get second opinions or double check your care with the help of a myeloma expert. So this is so nuanced, and we're just talking about one very small slice of myeloma care, right? Just bone pain management. I always recommend the use of the help of a myeloma specialist, and you should all have one on your team. Okay, Stephen had a question that's kind of interesting. There are other agents that stimulate osteoblasts, like strontium and fluoride, or older, like 60s and 70s studies. So why are some of these other therapies not being considered in myeloma care? They might be less expensive than what we have right now.
I'll answer one part of it, and Dr. Raje will answer the other part. Dr. Kyle, in the late 70s, did a randomized study of calcium, fluoride, vitamin D versus calcium and D. The addition of fluoride provided no benefit at all. And so even though it makes logical sense, fluoride probably needs to stick for cavity prevention. It's not going to make your bones stronger.
Okay.
Yeah, and I'll just add to that, strontium has also been studied and not been shown to be very effective. But we have better bone anabolic agents now, as I've mentioned, and we are studying them. They're not quite ready for prime time. They're not yet approved. So that's part of the reason they're only in the context of clinical trials as we speak.
Mm-hmm. Okay, great, good to know. So, Dr. Gertz, you kind of mentioned earlier that bone lesions don't necessarily go away, they kind of change. And Peggy was saying I had 4 lytic lesions when I was diagnosed. She gets body scans every year. Is it possible that they just stop showing up? And even though, they don't really go away?
So it depends on the imaging technique. If the imaging technique is with PET, PET is actually measuring the metabolism of the plasmacytomas. And when you have effective therapy, the CT component of the PET will show the lytic lesion, but there'll be no uptake of the fluorodeoxyglucose, the metabolically active component of the PET. So they'll become PET inactive, even though they're lytic lesions. So it depends on the imaging. In addition, MRI will show the lytic lesion, but will actually show what they call sclerosis around the edges, which is a form of bone healing, or can demonstrate fatty filling of the lytic lesions. So if they're filled with fat, they're not filled with myeloma. So depending on the type of imaging agent, you can actually see changes that are actually provide important information, but the actual hole closing up, if you will, that would be a no-go, because if you will, the scaffolding of the bone, the bone is really 2 parts. There's this cartilage framework, and on the cartilage framework, you hang the calcium, which makes it strong. And the myeloma destroys that cartilage framework, so there's nowhere to hang the calcium anymore. There's nowhere to put it. Mm-hmm. That cartilaginous frame that children develop before it fully mineralizes, there's nowhere left to repair, and so the hole doesn't fill.
Mm-hmm. Okay, interesting. There are a lot of questions that we have about specific activities. I think they were kind of flagged by your comment. You're worried about the spine, Dr. Gertz. So like golf, tennis, things that have a lot of twisting motions. Maybe this is just something that people need to talk to their doctor about specific activities. But do you have any general
I let a lot of people golf, but I'm really not interested in them shooting for a 350-yard off the tee drive. So I think that there's extremes about how much torsional rotation you can permit of the spine, and so if you're going to try and play like you're 25, I think it's a bad idea. But if you're going to just do a reasoned stroke, I don't tell people not to golf. It's, for some people, too much part of their personality. Mm-hmm. And I mentioned sitting in a card table chair and doing dumbbell weights. That's fine, but I don't want you putting 100 pounds on a barbell and doing squats, because there's just too much vertical stress on your spine. I really worry about the back in patients, because even when they're under control, their bone mineralization is not normal, and I really do worry about vertical mechanical stress leading to a compression fracture. It bothers me.
Mm-hmm. Dr. Raje, do you have any comments?
I think make sure first see what your risk is. I do think being active is a good idea. We have plenty of people, like Maury said, we don't say don't do it, but if you have a specific lesion which is at a risk, you've got to be very careful. Certainly, weights to that extent is not something we recommend, but up to 20 pounds, things like swimming, these are good exercises for the spine, and you should be doing them.
Mm-hmm. So Tom has an interesting question, because a lot of patients with bone pain are on heavy dose opioids sometimes to just manage the pain. And since some of that, sometimes bones heal over time, or certain, you talked about myeloma therapies reducing the pain in general. Are there times where you should pull back kind of on those pain meds kind of reassess your pain levels, and then how do you do that with your patients?
I think very important because, you know, the pain medications itself can impact your quality of life, can make you tired, can make you do less in terms of physical activity. And as your myeloma is under control, your pain, bone pain should also be under better control. There are certain situations, specifically, you know, the spine, where you have mechanical disruption of the skeleton, and that can, because of the mechanics of the way the spine is, you will end up with low back pain or mid back pain. So those things can sometimes be helped by procedures that we've talked about, the kyphoplasties and the vertebroplasties. I think exercise and building muscle around the spine is also helpful with pain control, but reassessing your pain requirement over the course of your disease and trying to cut back on some of it is always a good idea.
Mm-hmm.
So it's a very important question to begin to close on. And I agree with what Dr. Professor Raje said. Understand that if you fractured 5 or 6 vertebrae and you've lost 4 inches of height and now you're kind of hunched over a bit, then there may be no myeloma, but your spine is no longer doing the job of maintaining your vertical height. Now your paraspinal muscles are doing a lot of the work of keeping you up. So you're on your feet for a couple hours and your back really starts to ache quite a bit. Not the acute pain when you were diagnosed, but it's still sore. Think of it this way, and you may actually try this when we go offline. If you stand vertically, you could probably stand in one position for an hour. If you bend your knees and stand, just bend them 20 degrees, you're not going to get 10 minutes because all of the work of standing isn't being done by the bone. It's being done by your quads and your hamstrings and your calf muscles. And that's what happens in a deformed spine with multiple fractures. It will hurt toward the end of the day. And so when I say that the myeloma pain control, I don't mean it gets rid of it completely. Mm-hmm. But being on long-term opioid treatment, if you're thinking myeloma today and you're expecting 10, 15, 20-year outcomes, that's an awful long time to be on morphine or fentanyl. And you need to have a hard talk with the doctor about, can I substitute a non-steroidal agent or acetaminophen or just something that's not an opioid with the confusion, sedation, constipation, urinary hesitancy. Once the cancer pain is gone with treatment, it doesn't mean there's no pain. And again, Dr. Raje said mechanical pain, that's what it is. It's pain because the spinal geometry has been altered, and the prospect of being on opioids, open-ended, indefinite, no end in sight, when the pain itself isn't necessarily getting better, even with kyphoplasty, you need to have a serious talk. That's a long-term time to be on opioid analgesics.
Yeah, I agree. So I think we have time for maybe 2 more questions. So Dr. Raje, you talked about using bone strengtheners during the course, while you're on myeloma therapy. Does that include maintenance therapy? So, yeah.
Yeah, so, you know, I think it's really important to understand what your myeloma is doing. When your myeloma is active, being on frequent bone-targeted agents is good. Once you're on maintenance, I typically, after the initial treatment of monthly bone-targeted agent, will switch to every 3 months. And then beyond that, when somebody like an example which we discussed earlier, post-transplant incomplete response, how often do you need to give the bone-targeted agent? There's really no good data here, but this is where you can pause and revisit what is the risk of bone-related problems versus what is the risk of me continuing this bone-targeted agents. And oftentimes, if you have somebody who's been in remission now for 3 and 4 years on maintenance lenalidomide, for example, I will almost treat that person as somebody who is at risk for osteoporosis, so giving them either zoledronic acid or denosumab every 6 months or once a year. And those are the kinds of discussions you have to have with your healthcare provider. So it's going to be different for different people, but certainly decreasing the intensity of whatever you're doing in terms of a BTA is really important.
Mm-hmm. Okay, great. Great advice. And the last question I've seen, and I'm not familiar with Prolia at all, but I've seen a lot of questions in the chat about Prolia. Should I get Prolia? Is it going to impact the other bone strengtheners, my myeloma care? So maybe someone wants to describe what Prolia is, and then how it should be used.
Isn't Prolia denosumab?
Yeah. So
Yeah,
Prolia is
it's just
Oh, I
denosumab.
thought it's Xgeva.
there are two companies that can market denosumab in
Oh,
the
okay.
United States. So everything that's been said about denosumab, Dr. Raje wanted to use generic names as we've been instructed to, but most patients are familiar only with the trade names. Prolia and Xgeva are the same.
Well, I was
The
so
only
used to
difference, Jenny,
yeah.
is when you Prolia, the indication is osteoporosis. Xgeva, the indication is myeloma.
Well, you
That's
learn
the
something new every day. I had no idea. Okay, I'm thinking it's this new osteoporosis drug that I should know about. So I had no idea. Well, we're at our time. I would like to just share, I'm not going to do any kind of demo on HealthTree, but we do have a new feature coming out that shortly that I would like to just kind of give everyone a heads up for, and to use that new tree. I'm going to keep you in suspense about what it is, but it will help with what we've talked about today. And it's important that if you use HealthTree, you go in and add your treatments, your prior lines of therapy, and your side effects for those, because your experience will help other patients. And I think that's all I'm going to say about it. But we're pretty excited to release a new feature in that coming up soon.